Oh, right at the 12 o'clock mark, and we have already almost 40 people. The attendance and participation has been fantastic so far. And welcome to the second Grand Rounds, Roy Benke Grand Rounds for the Department of Internal Medicine. Last week, we saw one of our young faculty stars and Juan Carlos Cardet, who gave us a rousing asthma talk. And we have yet another of our young faculty superstars in Dr. Jacqueline Sherbuk, who will be talking today, who will be speaking today. She's an assistant professor in the Division of ID and International Medicine under the great leadership of Dr. Kami Kim as Division Director of ID. Originally a University of Virginia Cavalier, she is a graduate of the New York University School of Medicine, and then found her way to Yale, New Haven, where she did a residency in internal medicine for finding her way back home to University of Virginia at Charlottesville for her ID fellowship. Quickly diving right into her faculty years here, she has already been a successful procurer of CDC and NIH funding for HIV care research, and she has 3 very vibrant, active grants. She also has taken on the medical directorship of the University Area Health Clinic and Hillsborough County STD director, STD program director, as she has on her title slide. She has already double-digit publications, peer-reviewed publications, poster presentations, and oral presentations she's given at scientific meetings. Truly one of our young faculty stars. It is a pleasure to introduce Dr. Jacqueline Sherbuk, who will be talking about DoxyPEP for STI prevention. Welcome, Jacqueline, to our Grand Rounds, and go for it.
Thank you. Thank you for that very kind introduction. And I'm honored and thrilled to be able to talk to everyone about DoxyPEP today in my role as medical director for the county STD programs. This has been a big topic of discussion and very much on our minds in the past year or so. I have no disclosures, and the learning objectives are available here and on the flyer. So to start with, what is DoxyPEP? We'll make sure we're all on the same page here. So DoxyPEP is doxycycline, the antibiotic we all know well, and the PEP part is post-exposure prophylaxis. So this is doxycycline taken after a sexual encounter for the prevention of bacterial STIs. And for the purposes of this talk, when we're talking about STIs and bacterial STIs, we're talking about chlamydia, gonorrhea, and syphilis. We know that for chlamydia, doxycycline is the recommended treatment. For syphilis, doxycycline is an acceptable alternative to our preferred treatment of penicillin, something we've all come across with the current penicillin shortage. And for gonorrhea, doxycycline can be effective pending resistance patterns. Even if we haven't heard about it much in the medical community, this is getting out there into the news and patients are starting to ask about it. Here I added a couple headlines with pretty exciting titles. Talking about how there's a morning after pill to prevent STIs and an old drug offering a new way to stop STIs. So DoxyPEP is out there, and these articles have all been published within the past year, and it's definitely gaining more traction as we learn more about it. So to understand why we're talking about DoxyPEP today, it's important to first understand the current where we currently stand with STIs in terms of epidemiology and complications. So STI cases are rising in the United States. Chlamydia is the most common STI, and this cases of chlamydia over the past 5 years from 2017 to 2021, which is the most recent year we have data for, have been pretty stable, technically a drop in about 4%. But cases of gonorrhea have been steadily rising over the same time period, and compared to 5 years ago, cases are up 28%. And for syphilis, the rise in cases is even more dramatic, with a 74% increase in syphilis cases over the past 5 years. We know that STDs do not affect everyone equally. Based on age, race, ethnicity, gender, where you live, there are disproportionate distribution of STIs. For the purposes of this talk on DoxyPEP, I wanted to focus in on the disproportionate rate of STIs we see in men who have sex with men and transgender women. And the current estimates are that about 40% of new cases of gonorrhea and syphilis are occurring in men who have sex with men. This is clearly disproportionate to the percentage of the population that these groups make up. We know STIs are rising. We also know that STIs have serious complications. Without treatment, STDs can cause increased risk of giving or getting HIV. If you say have syphilis and you have a genital ulcer and then you're exposed to HIV, it's more likely that you're going to acquire HIV because HIV can pass our natural barriers. If you already have HIV and then you also have an STD, that you end up shedding more HIV virus, so there's a higher risk of transmitting HIV to others. STDs can also cause pelvic inflammatory disease, which has serious long-term complications of pelvic abdominal pain. It can also cause tubal factor infertility and also cause pregnancy complications, namely ectopic pregnancies. We also know that there are thousands of cases of neurosyphilis occurring per year. If any of you have done inpatient time at Tampa General, you'll know that we see this pretty regularly here at Tampa General, that we're treating neurosyphilis or ocular syphilis, and these can have prolonged complications. People do not always get back to their baseline after treatment. And then one huge topic in public health these days is congenital syphilis. You may have seen it in the news or in websites. The blue bars show the rate of syphilis cases or the number of cases in pregnant women over the past 5 years. You can see that cases are just shooting up at an even faster rate than the overall increase in syphilis cases in the country. And then as far as congenital syphilis cases goes, cases have more than tripled over the past 5 years. In 2017, there were about 700 cases of congenital syphilis nationwide, and now there are over 2,000. Another public health concern related to STDs is antibiotic resistance, particularly in Neisseria gonorrhea. The CDC has some surveillance systems to try to track the frequency of antibiotic resistance in gonorrhea. And so this graph shows the rates of resistance over about 20 years. And I've highlighted here, since we're talking about doxycycline, the rate of tetracycline resistance in gonorrhea. And the rate has hovered around 20%, some fluctuations, but 20% of isolates of gonorrhea are resistant to tetracyclines. We are not left with many treatments for gonorrhea that we are confident will be successful. The main one we have right now is ceftriaxone, which is the current recommended first-line treatment for gonorrhea infection. But we are hearing reports of elevated MICs to ceftriaxone, and there was a report out of Boston earlier this year, out of Massachusetts, detailing a case with elevated MICs to ceftriaxone. So antibiotic resistance, a huge topic for gonorrhea. And since I did note that elevated MICs to ceftriaxone, the cases that was noted in, people still responded to ceftriaxone. So just so no one gets too nervous about this. And the current strategy for prevention of STDs is talk, test, treat, meaning talk to your patients about sexual health, talk about how they can prevent STIs and protect themselves, test as recommended either for symptomatic cases or in the cases of asymptomatic people as per screening guidelines, and treat when you find an STI. But I would argue that based on the rising rates of STDs we're seeing nationwide and the very real complications that STDs can cause, that current STI prevention approaches are not sufficient, and we need new strategies for the prevention of STDs. And so this is where DoxyPEP comes in. So I think it's interesting to think about where this idea of DoxyPEP even came from. I think a big player historically is the role of HIV PrEP, or pre-exposure prophylaxis. HIV PrEP has been very successful for HIV prevention, really empowered people to take control of their own sexual health. It's been effective in decreasing the rate of new HIV infections. And so I think people have seen this and said, well, we have this medication we can take to prevent HIV. Why don't we have a medication we can take to prevent other STDs? Antibiotic prophylaxis has been used previously for STI prevention in World War II on Navy ships. They used penicillin to take in after sexual encounters to prevent gonorrhea and syphilis infection. They found it hugely effective, prevented about 80% of cases of STIs. But you can find editorials from 1949 stating that they aren't sure this is a good idea. One, because it has to be taken so timely and it's tough to get the medication quickly to people. Another reason was concern for resistance to penicillin in gonorrhea and in syphilis, which was founded for gonorrhea. We haven't seen that resistance in syphilis. And then the third one was cost. And per the 1949 editorial, it was costing about $30 to prevent one STD. And so they weren't sure that was worth it. And then another factor that comes into play here is that post-exposure prophylaxis is already being used in a significant minority of men who have sex with men. So in surveys of sexual health clinics, 8 to 10% of men who have sex with men reported using non-prescribed antibiotics for STI prevention. Some are using it for post-exposure prophylaxis, some for pre-exposure prophylaxis, sort of all different methodologies, because these are antibiotics used not under the guidance of a physician. And if you go looking, you can find websites where you can order antibiotic pills from for a relative price. And so people are already doing this. They're trying to figure out how to protect themselves. And in the absence of guidance from physicians, medical societies, people are trying to do it themselves. Whether or not the way they're doing it is effective, we don't know, because people are taking all sorts of different antibiotics, doxycycline commonly used, but amoxicillin, azithromycin, things that may or may not actually be helpful for them. So now I'd like to dive into a few of the clinical trials to look at the data we have out there about DoxyPEP. So there's 3 trials I want to focus on today: IPERGAY, DoxyPEP, and DPEP. All 3 are randomized controlled trials. Most are randomized 1-to-1. DoxyPEP was 2-to-1. But they occurred in very different settings. IPERGAY was done in France. DoxyPEP was performed in the US in Seattle and San Francisco. And DPEP was a study done in Kenya. As far as the population enrolled in the trial, IPERGAY and DoxyPEP were similar. They focused on men who have sex with men and transgender women, either on PrEP or living with HIV. And they tried to get to people at high risk for STIs during the trial period. So IPERGAY required that people reported condomless sex with multiple male partners in the preceding months. And DoxyPEP, sorry, the light went off in my office here. And DoxyPEP required that people have an STI in the prior year and reported condomless sex with male partners. DPEP was a very different study, and DPEP focused on women ages 18 to 30 years who were taking PrEP in Kenya, and there was no requirement for prior STIs in this study. And in this column, I'm going to give you the overall results, but we're going to go through the results of each trial separately. The big highlights are that IPERGAY and DoxyPEP showed substantial reductions in STIs. In IPERGAY was 47% reduction in all STIs, and in DoxyPEP there was a 2/3 reduction in all STIs. In DPEP, there was no difference seen in STIs. We're going to go through each of these trials, starting with the IPERGAY trial. So IPERGAY trial had about 116 people in each arm. They were equally distributed. And the standard care group, which did not receive any DoxyPEP, had significantly more STIs occur than the DoxyPEP group. You can see the 47% reduction here. And interestingly, I thought 39% of participants accounted for 86% of STIs, which is something we'll come back to later on. And in the IPERGAY trial, if you break down those total STIs by the specific STI, we see some interesting results here. So gonorrhea was the most common STI, but there actually was no change in gonorrhea rates between people on DoxyPEP and people on standard care. Chlamydia was the next most common, and here we saw a substantial reduction in chlamydia, a 70% decrease in cases in the group that used DoxyPEP. And then for this one, we saw a 73% reduction in syphilis cases in the DoxyPEP group. Pretty impressive results as far as chlamydia and syphilis go. Moving on to the next trial of DoxyPEP, and I can't remember if I already said this, but DoxyPEP, the way it is taken in all of these trials is you take a single dose of 200 milligrams of doxycycline, ideally within 24 hours after a sexual encounter, a condomless sexual encounter. And in the DoxyPEP trial, they allowed people to take that dose up to 72 hours later. In the IPERGAY trial, it had to be within 24 hours. So for the DoxyPEP results, their main outcome was STI incidence per quarter. And because they recruited both people on HIV pre-exposure prophylaxis PrEP and they recruited people living with HIV, they separated those two groups for the purpose of analysis in case there were any differences between them. So looking first at the PrEP cohort graph on the left, you can see that in the standard care group not prescribed DoxyPEP, there were 32% of quarterly visits had an STI detected. In the DoxyPEP group, that number was 10.7% of visits had an STI detected. So this is an absolute risk reduction of 20% or a little more between the groups and a relative risk reduction of 2/3 in the total number of STIs detected at quarterly visits. For the people living with HIV, you can see they split them out, but the numbers are very similar with around a 20% absolute risk reduction in STIs per quarter. They also saw a 50% reduction in ceftriaxone use in the DoxyPEP group. And they calculate a number needed to treat based on this of about 5 to prevent a bacterial STI per quarter. The DoxyPEP group also broke it out by each bacterial STI. And in this case, DoxyPEP, we actually did see a significant decrease in gonorrhea infections from about 20% had a gonorrhea infection detected per quarter to down to 9%. So over a 50% reduction, similar in the people living with HIV cohort. They also looked at it at the detection per anatomical site, but we won't get too far into that. And one thing that comes up is why did we see a difference in gonorrhea here in the DoxyPEP trial, but we did not see a difference in the IPERGAY trial? And one thing may be the underlying rates of tetracycline resistance. So in France, about 56% of gonorrhea isolates are resistant to tetracyclines, while in the US, it was only about 20%. Still more than we would like, but significant difference. And it's hypothesized that maybe that's part of the reason we see effectiveness here in the US, but not in France. For chlamydia, again, a dramatic drop in the PrEP cohort from 12% of quarterly visits detected chlamydia to 1.4%. And syphilis, least common STI detected again, but another significant drop from 2.7% down to less than 0.5%. So dramatic reductions in all three sexually transmitted infections in the DoxyPEP group. And they calculated risk reductions, and you can see there that there were significant drops in all three, but highest with up to 87%, 88% reduction in chlamydia and syphilis in the PrEP cohort. And a couple takeaways from these trials or other key data points. In terms of how often was doxycycline used in these trials, in the IPERGAY, it was about 3.5 doses per month, and DoxyPEP about 4 doses per month. So once a week-ish, people were taking a dose of DoxyPEP after a condomless sexual encounter. Self-reported adherence was pretty good in both. Mid 80% of people reported using DoxyPEP with any condomless sexual encounters. And a small percent of people in both groups discontinued DoxyPEP due to adverse effects. The adverse effects noted were all GI side effects or intolerances. No severe adverse effects were seen with DoxyPEP. And a couple additional people discontinued because they felt they no longer qualified. They had one stable partner and only that partner. So, but for the most part, the trials were pretty similar in terms of use, adherence, and need to discontinue DoxyPEP. So those are our two RCTs in men who have sex with men and transgender women. Now we'll take a look at the DPEP trial. So this was looking at DoxyPEP, and it was taken the same way in those other trials, a single dose of 200 milligrams doxy, taken 24 to 72 hours after a sexual encounter. But this trial looked exclusively at cisgender women in Kenya. And they had 449 participants, and they did find a group that had a decent rate of baseline STIs on screening. 18% had an STI on their initial encounter. And during the course of the trial, they detected 109 STIs, but there was no significant difference between groups. Women in this trial reported adherence to DoxyPEP of 78%, slightly lower, but pretty similar to those other randomized control trials. And this graph just again sort of highlights the point. This is time to first incident STI. The blue line is DoxyPEP, the red is standard of care. I think we can all tell there's no difference between these groups in the use of DoxyPEP to prevent STIs or the time to STIs. So this has raised a really big question. Why was DoxyPEP ineffective in these cisgender women when we know it's effective in other groups? And three main hypotheses have been thrown out there. One is it resistance to antibiotics? Is it some anatomical reason? Is the endocervical and vaginal tissue different from rectal urethral tissue? And the third question is adherence. And adherence was self-reported. Was it accurate? So starting with resistance. Gonorrhea resistance is common, and they took a small number of isolates from this group, the DPEP trial group, and they looked at them. And gonorrhea resistance was tetracycline resistance to gonorrhea was very common, but there is no known chlamydia resistance to doxy, and syphilis was not resistant to doxy. So it seems unlikely that any resistance in gonorrhea alone would explain the lack of change in any STI. The next question was anatomical differences. Drugs concentrate differently in different parts of the body. So was the doxycycline dose given able to concentrate in vaginal and endocervical tissue at appropriate levels? And so people have studied this. They give volunteers a dose of doxycycline 200 milligrams, and then they record the levels at different time points. And the blue line here shows vaginal secretions. And so you can see it peaks pretty early, within 8-ish hours, and then slowly falls over the next couple of days. Rectal secretions in the red square peak a little bit later and plateau a bit before falling. But you can see that it gets to similar peak levels in vaginal secretions as rectal secretions. So then you look at how high above the MIC are these concentrations getting. And I've highlighted here the vaginal and cervical tissue. And especially for chlamydia and syphilis infections, the level of doxy getting into vaginal and cervical tissue is manyfold higher than what you think you would need to be an effective dose. And so the thought based on these data is that it really predicted that DoxyPEP should work in women to prevent STIs. So then we're left with one other question, is adherence. People reported good adherence. It's difficult to measure because you can only really have self-reported sexual encounters. So the DPEP group planned as part of their study to do hair testing for doxycycline. And so they tested it for doxycycline levels. And in the DoxyPEP intervention group hair testing, the results showed that 56% of women had doxy detected at least once in a quarterly visit, which means nearly half never had a dose of doxy detected at a quarterly visit. And only 29% of all quarterly visits had doxy detected. And it may not be indicated for people to have doxy detected at each visit if they haven't recently engaged in condomless sex, but these numbers seem lower than expected based on the frequency of sexual encounters and the timing that people were reporting. So this data was recently presented just a month or so ago, and it remains an area of ongoing study to figure out what is going on here. So the summary of the randomized control trial is that DoxyPEP has been proven to be effective in preventing bacterial STIs in men who have sex with men and transgender women. And the number needed to treat to prevent an STI per quarter is about 5 people. DoxyPEP has not been demonstrated to be effective in cisgender women. And DoxyPEP is generally well tolerated, and people are comfortable using it. So now, that's all the good data, but now we know that there's a reason we're not just giving everyone doxycycline out there. There are a lot of unknowns here and a lot of potential harms of doxycycline use. So here I've listed a few, though there are many more. One, with any medication, we give people side effects, GI side effects, photosensitivity, drug eruptions, many more rare and serious side effects. GI were certainly the ones that came up in clinical trials, though we know if we expand it to more people, we will see more side effects. Impacts on the microbiome. We know antibiotics can clearly affect the microbiome, and what that means and how we interpret that is an area of ongoing research. And then impact on bystander bacteria. So bacteria that we're not targeting when we use DoxyPEP, but that are affected by DoxyPEP anyway. And the big one that's really being looked at here is Staph aureus. And so in the DoxyPEP trial, they looked at Staph aureus colonization and resistance at baseline and then at 6 and 12 months time points in the standard of care group as well as the DoxyPEP group. And so here's what we find. These show the rates of colonization. The yellow bars are at baseline. So in both the standard of care and DoxyPEP group, 40-something% of people were colonized with Staph aureus at baseline. In the standard of care group, it fluctuated, but no significant differences were seen at 6 and 12 months. And then in the set of columns for the DoxyPEP group, there was a significant reduction in the rates of Staph aureus colonization in the people taking DoxyPEP. So then they took this data and they said, well, out of those isolates we're identifying from people who are colonized, how common is doxy-resistant Staph aureus? So in the standard of care group, the rate of doxycycline resistance and colonization actually went down a bit throughout the trial, not significantly. And then the DoxyPEP group, at baseline, only 5% of people had doxy-resistant Staph aureus colonizing them, but that had an 8% increase, absolute increase, to 13% later on in the study. And that was a significant difference. So it looks like through the use of intermittent DoxyPEP with sexual encounters, you have a decrease in the total rate of Staph aureus colonization, but an increase in isolates that are doxy-resistant out of those that you do have. And then another potential harm, and this is such a big one, is antibiotic resistance in STIs. We already looked at the data for antibiotic resistance in gonorrhea. And then the other STI that this is really a concern for is Mycoplasma genitalium, MGen, which is not a very well understood STI, but it's also very difficult to treat STI. And right now, doxycycline is part of the sequential therapy that is recommended for the treatment of MGen infection. So if we develop further resistance in MGen, will this be even trickier to treat in the future? And they did try, again, in the DoxyPEP trial, very thorough trial, they tried to look at the presence of tetracycline-resistant Neisseria gonorrhea. So the first column is at baseline. And I think one important thing to note is if you look at the total number of isolates they're looking at here, it's 17 isolates at baseline, 19 for the standard of care intergroup, and then 20 for the DoxyPEP intervention group. There were only a small percentage of cases of gonorrhea where they had cultures available with MICs. And so that really limits the data here. But at baseline, you can see that 76% were presumed to be susceptible to tetracycline, and then 24% had elevated MICs, with a small percent having high-level resistance. In the standard of care group, nearly all were susceptible to tetracycline, except a couple. And then in the DoxyPEP group, it does look like you have a little more than in the standard of care group of isolates that are doxy-resistant. So it's too early from the data, and this is very limited data, to discuss the impact of DoxyPEP on tetracycline resistance. The authors of this study concluded that based on this data, that DoxyPEP may not be as effective against resistant or high-level resistant to tetracycline isolates of gonorrhea. So now we come to the question of implementation. We have multiple randomized controlled trials. And so what do we do now? So should we implement DoxyPEP? The CDC has not provided formal guidance on DoxyPEP implementation. They have acknowledged that it's a topic of discussion, and they have acknowledged that it exists, and they posted a statement saying that they are awaiting further information about many of those potential harms and unknowns that we've outlined. The second point here is that the communities most affected, particularly men who have sex with men, have expressed interest in DoxyPEP as a tool for empowerment and sexual health. And there's forthcoming qualitative data showing that people really find this to be a wonderful tool and something that they feel pretty strongly that there's data showing it's helpful. And so why aren't we offering it to people who could benefit from it? The general sense around STI experts, though by no means the only opinion, is that there's an abundance of evidence that DoxyPEP is effective, but there are a lot of unknowns and potential harms. And most STI and sexual health clinics are moving towards cautiously implementing DoxyPEP. I think it's important to remember that DoxyPEP is one tool for STI prevention. We know that in public health issues, it's hard for one intervention to really change it. So it's one tool, and it's best used in combination with other prevention strategies. So still education and counseling and talk of condoms and HIV PrEP, and all of those should all be part of a discussion regarding DoxyPEP. We have our earliest data of real-world implementation and uptake of DoxyPEP that comes out of San Francisco. San Francisco was very proactive as these trials started coming out on DoxyPEP. And a little under a year ago, the San Francisco Department of Public Health put out a health update about DoxyPEP reducing the incidence of sexually transmitted infections. And they lay out in this document criteria for who should be offered DoxyPEP, considerations of how you should counsel people, and really a good protocol to follow for implementing DoxyPEP. And at a recent conference, they presented some of their initial data on the uptake of DoxyPEP. So they started offering this in November 2022. And since then, they've had 828 people who they've prescribed DoxyPEP to. They use the same inclusion criteria as the DoxyPEP trial. So men who have sex with men and transgender women with a bacterial STI in the past year and condomless sex with a male partner. They do not recommend DoxyPEP for cisgender women based on the available data. And then they looked at uptake. So clearly a high number of people were interested in this, and the uptake was really highest in those who had prior STIs and those who reported having multiple sex partners. Those were the most likely to hear about this and say, yes, I want to try this. Among those who received DoxyPEP, they used it about 4 to 6 times per month. So that's very similar to what we had seen in those clinical trials, maybe slightly more. And DoxyPEP was used after about 70% of condomless sexual encounters. So a little lower adherence than what we saw in clinical trials, still a significant amount. And it's important to note that this trial was taking place in San Francisco, is based out of sexual health clinic prescribing PrEP. And so a population that's very tuned into this topic of STI prevention. They do not yet have data on the incidence of STIs that is forthcoming. So I think there are some big public health considerations in the implementation of DoxyPEP. The first one is really, can we better identify which people may benefit most from DoxyPEP? So we looked at that first trial, the Ipergay trial from France, and I commented that 39% of people accounted for 86% of STIs during the course of the study. Is there a way to better focus in on the people who have the highest rate of STIs and would get the most benefit, the most bang for your buck from DoxyPEP? And people are starting to look at this. The next one is, how do you integrate DoxyPEP into sexual health programs, PrEP, HIV, STD programs? These are probably the highest yield place to integrate DoxyPEP. How do you do that? And then a big question is, how can you ensure DoxyPEP implementation is equitable? And here I think some of this draws on our past history of our prior STD prevention tool and pre-exposure prophylaxis for HIV. HIV PrEP has been a wonderful tool for prevention of HIV, but the implementation has not been equitable. We know that based on race, education level, socioeconomic status, some people are much more likely to be receiving PrEP than others. And if we're, if we're implementing a new STI prevention tool, how do we do this better this time? How do we make it more equitable? And that's a big question in the world of public health right now. And then going back to that first point on the prior slide, can we optimize the use of DoxyPEP based on selection criteria? So who do we offer DoxyPEP to if we're implementing it? So this is a study that came out earlier this year. They took data from a Boston sexual health clinic, Fenway Clinic, and they included anyone who during the years of 2015 to 2020 had been tested for STIs at least twice. And so in that time frame, there were like 10,500-ish people who had been tested for STIs at least twice. And then so they did some analysis of if, say, they had offered people DoxyPEP based on different criteria, how many people would they have to prescribe DoxyPEP to, and how many STIs would they prevent? And so this is sort of their results from that. If you take the top bar here, if you prescribe DoxyPEP indefinitely to all people who were tested for STIs at least twice at this clinic, you would be prescribing DoxyPEP in the blue bar. That's how many people you're prescribing it to. So you'd be prescribing DoxyPEP to 100% of people. And you would prevent 71% of STIs is the estimate based on current data on the effectiveness of DoxyPEP. So you'd be preventing a lot of STIs, but you're also giving out a whole lot of doxy. And they looked at it, you can see below that bar that I've highlighted, they looked at what about if you focus on people living with HIV or people who use PrEP. And then they looked at the bottom half or more of this chart is looking at if you give DoxyPEP for 12 months following certain indications. So say you give DoxyPEP for 12 months following an STI. You'd be treating 38% of these 10,000 people with DoxyPEP for a year rather than indefinitely, and you'd prevent 39% of STIs. So some trade-off there in how many STIs you prevent, but a whole lot less DoxyPEP out there in the world than with giving it to everyone. And you can look at, they broke it down different ways by rectal STI, by a history of gonorrhea or syphilis, by the number of STIs in the past 12 months or 6 months. And if you look at the people who had 2 STIs in the past 6 months, you'd only be prescribing DoxyPEP to 10% of these 10,000 people, but you'd be preventing 16% of STIs. So I think it's a topic of discussion of where is the right breakpoint, what is the best criteria, and how can we optimize this to try to weigh those known benefits with all those potential harms we see. And then they took this data and basically turned it a different way into the number needed to treat for 1 year to prevent 1 STI. We know that the earlier trial showed that the number needed to treat was 5 to prevent a quarterly STI. So this is looking instead at a different time frame for 1 year. And I highlighted the same criteria for prescribing as we looked at on that last figure. So if you start with the orange one, if you prescribe it to all people who've been tested twice, you'd have to treat 4 people for 1 year with DoxyPEP to prevent 1 STI. And if you use the blue criteria of any STI, you'd have to treat 2.4 people to prevent 1 STI. And if you get down to some of these more narrowed groups, like people who've had 2 STIs in the past 6 months, the number needed to treat is only 1.3 to prevent 1 STI in a year. So that's an area that people are really focusing on. And then there's also more specific questions that sort of relate more to the individual care of patients who are using DoxyPEP, whether you're the one prescribing it or the one seeing someone who's using it. And so one question that comes up, and I heard someone present or discuss this framework for how you talk about interventions with patients. So do you recommend DoxyPEP? So are you strongly saying to them that you would benefit, you should take this? Or do you offer DoxyPEP? Do you say, hey, here's something maybe you want to think about? Or do you inform about DoxyPEP? Do you say, oh, here's a flyer with some information about DoxyPEP? I think we know as physicians that how we present things to patients really impacts how they understand the intervention and the benefits and the harms. And so how strongly do you recommend it or not? And do you do this equally for all different groups of people? And then everyone agrees that DoxyPEP should be offered as part of a shared decision-making model. But how do you actually acknowledge those benefits, harms, unknowns? There's a lot of unknowns, and it's hard for even experts in this field to weigh the benefits and the harms. So how do you discuss that as an individual? Other more detailed questions that come up is how many pills do you even prescribe? Will the pharmacy fill scripts? It's not a typical prescription to write, take Doxy PRN as needed. We usually don't do that with antibiotics. And then other questions about the care of patients. How often are you screening for STIs? I would say most of the clinics that have implemented this and have talked about it still continue with about quarterly screening for STIs, similar to how we manage patients who are taking PrEP. And in many cases, clinics are rolling this out to people on PrEP. So that's sort of an easy, we're already doing it, screening people quarterly for STIs on PrEP. So this is sort of simple to work it. How do you manage people who are contacts to STIs? Typically if someone came to you and said, I had an encounter with a person 2 weeks ago and now they tested positive for gonorrhea, you would empirically treat them per guidelines. But what do you do now if they can't come with the same story and they say, oh, but I used DoxyPEP the next day? Do you manage them as a contact or do you say, let's wait and see? Will DoxyPEP affect interpretation of syphilis serologies? Syphilis tests can be very challenging to interpret And especially in people who are at risk for reinfections, we often need that RPR titer to help us guide us into whether they've had a reinfection that requires treatment or not. And if people are taking these intermittent doses of doxy, how will that affect those RPR titers and what will we do with them? There are a lot of resources available out there. And again, these studies are all very new. This is a very new area, but as more and more clinics are implementing it, they're rolling out advice for providers, for patients. I included a couple here that are flyers. These are more patient targeted. But a graphic illustration or an illustration or a graphic feature of how to take DoxyPEP. When do you take it? What if you have multiple sexual encounters within a day or days in a row? How often should we take it? And so these sort of lay that out. And then the information sheets are just talking about what is it? When should I take it? What do we know? What don't we know? And so forth. And so what's next for DoxyPEP? There's a lot going on in this area of research. There's ongoing trials for DoxyPEP versus DoxyPrep, which is doxy pre-exposure prophylaxis taken daily, similar to HIV PrEP. There's a couple trials on this, one called syphilaxis, so syphilis prophylaxis. We need more data on a lot of topics. We need more data on gonorrhea resistance, both in people on it and at a population level. We need more data on microbiome and bystander resistance. There are coming at prevention from another direction. There are vaccine trials out there for STI prevention, and the ones sort of furthest along really focus on gonorrhea prevention through vaccination. We need more data in women. While women have lower rates of some of these STDs, they do bear the burden of many of the complications related to PID, chronic pain, infertility, congenital syphilis. And we need official guidance from the CDC. So in summary, we know that STI cases are rising in the United States, especially in gonorrhea and syphilis infections. We know that our current STI prevention strategies are not sufficient, and we need new strategies. So doxycycline as post-exposure prophylaxis now has multiple randomized clinical trials demonstrating effectiveness in reducing STIs in men who have sex with men and transgender women, though we do not have data showing effectiveness in cisgender women. We know that there are many unknowns and potential harms of doxycycline post-exposure prophylaxis that we really need to more research to learn more about. And there are a lot of things to think about in implementing DoxyPEP, including how to optimize our use, how to make sure implementation is equitable, how to discuss it with patients. And future directions. There's a lot of ongoing research for DoxyPEP, so I think we should all expect to be hearing more about this in the future as more data comes out. So that's my talk. I made sure to leave time for questions at the end. I would like to give some specific thank yous to the USF Infectious Disease Division, especially Dr. Sharon Sambunwit, who has been a mentor through all of this for me. Shout out to the University Area Health Center, which is our county STD program, as well as the Hillsborough County Health Department, and John George is our APRN, who has been really a pioneer in leading DoxyPEP in our county, and the Sylvia Rattel HIV Prevention Training Center, Kathy Hsu, Dr. Kevin Ard, Janine Dreyer, who have really been key in my development and learning about STD world. Thank you.
Thank you very much. Excellent. And how blessed you are to have Shahrukh as a mentor. So just an outstanding faculty member that I've had the pleasure of knowing for 20 years. But I'm not supposed to say that. I'm sure that's what Shahrukh is going to text me. Stop saying 20 years, Joe. Any questions? We'll open it up to the audience for some questions.
There's a question in chat.
Yeah, go for it.
At what point in a pregnancy will doxy affect the fetus?
Yeah, so doxycycline is contraindicated in pregnancy. And so that's a great question. And I did, it became an issue in the clinical trial of DPEP in cisgender women in Kenya, where a fair amount of time they had to stop doxycycline because women were found to be pregnant. And so that became a challenge in that trial.
And we have Dr. Shyla Moore-Pardo as our APD in infectious diseases for our outstanding fellowship program. So Shyla, go ahead.
Yes, Jackie, thank you for that great presentation. I think you did a great job just bringing the facts from the randomized clinical trials for those of us who haven't been able to read it. My question is, we've had some preliminary discussions here in our VA ID division about how to best implement this in terms of, equity. And also from an ASB standpoint, our veterans are very educated, our MSM population, as well as our LGBTQIA community. They are asking about it. They are expressing their interest. However, we haven't had an opportunity to roll out a protocol yet, since we are waiting for more data and more guidance from the CDC. Any preliminary discussions on? I'm just curious on how the health department at Hillsborough County may or may not implement this, if you're allowed to say.
Yeah, well, I'm gonna say it. So we at the STD clinic, the University Area Health Center, and really under the leadership of John George, our APRN, we have created a DoxyPEP protocol, and we are sort of running it through the varying levels of oversight. And we've really modeled it for now pretty strictly off of the DoxyPEP trial criteria. So very similar to how San Francisco has implemented theirs. Really, men who have sex with men, transgender women with condomless sex, multiple male partners. But I think there are a few things, and part of this was spurred by patients were starting to ask us about it. But if we're only responding to people who are asking, we are inherently not implementing this in an equitable manner, because as you said, the people who tend to know about it tend to be very knowledgeable, often educated, potentially higher socioeconomic status. And so we really thought it was important to develop a protocol for DoxyPEP that we could sort of apply more equitably across our patients. We are still struggling with some of those details I mentioned, like how strongly do we recommend versus offer versus inform. And sometimes that comes down to, the individual patient in front of you. Do you feel like they fit into one of those groups that those other studies suggest could benefit more? So if it's someone we keep seeing come back multiple times with STIs, they might be someone we're like, hey, let's really talk about this in more detail. So we are rolling it out, and the state of Florida is working on a protocol, as well as, in addition to CDC and many other organizations, the VA, as you mentioned, is in discussion. I think I see Dr. Morano's hand up as well.
Yeah, I know. So thank you for your answer. I am looking forward to seeing that data from the implementation of your protocol so that we can learn on best practices on it. Thank you.
Go ahead, Dr. Morano. Jamie Morano, infectious diseases. Go ahead.
Hi, no, thanks so much. Great talk, Dr. Sherbuk. Thank you, Dr. Lozama. Absolutely. National VA is having these discussions, and I so appreciate the presentation of the data. And something that we were discussing on the national scale is exactly how do you standardize protocols and how do you create equity, both in DoxyPEP being offered and frankly, in the number of prescriptions being given. We've all had those cases where, patients are self-treating with Doxy for an upper respiratory infection or having rashes because of actually overdose of Doxy. So I agree, it's a balance. Locally, we have had those discussions, and I agree there are a lot of pros and cons. We are offering it cautiously, but again, it's still in discussion, and I agree. It definitely, data will say, but yes, National VA is looking very closely at this. So hopefully, all the clinical trials will be able to coordinate something that makes sense. But, I think it's like a pendulum. I think everybody's really excited about it, but I think we have to also remember risk reduction in all different ways, right? So not just Doxy, but, other types of risk reduction as well. And sometimes there's the Hawthorne effect, right? When you put somebody in a DoxyPEP program, sometimes you have those discussions maybe a little more often. So you have to think about that too. But no, thanks. Great talk. Really appreciate it.
Yeah, and I didn't include this, but the IPRG and DoxyPEP both reported how like sexual behavior, and didn't see changes between the intervention groups and the standard care groups, but they did. I know IPRG in particular did see a decrease in some of those number of partners, number of condomless sex throughout the trial, which may be sort of what you're getting at just by the inherent nature of being part of this study. People may have changed behavior a bit, which can be very different from real world.
All right, we'll continue the litany of infectious disease doctors lining up for questions. So Then we'll have a little bit of a break and have international medicine next up for you. Good thing you left. You came prepared. The ID crowd is always ready to ask questions. This guy's been asking questions for decades. Dr. John Toney, go ahead.
Thanks, Joe. That was a really nice talk. I appreciate you taking the time to do it. I know we all have questions about it, and I think when you talk about the three most common sexually transmissible bacterial infections, 2 out of 3 is not bad. It's the gonorrhea one, unfortunately, which is not the highest prevalence one at this point, but it is still an ongoing issue for us. I like the positivities, but I also wonder about the negativities. And the biggest negativity I think that we haven't thought about, nobody's talked about, is what we're currently going through with syphilis. There's, a national shortage of benzathine penicillin, the Bicillin LA. So we've had to change to using doxycycline for that. So we put more pressure on using more doxycycline with that. Plus, doxy now is preferred if you're going to treat with gonorrhea instead of azithromycin. We found out, by trying to couple azithromycin with ceftriaxone to try and prevent ceftriaxone resistance. The only thing that we got out of it was azithromycin resistance. Plus, we also found out we were underdosing the ceftriaxone. So I guess my concern is we've already had, a few national shortages of doxycycline. Have you heard any discussion about using something like minocycline as an alternative? Because I brought it up when we were doing the CDC's prevention center things many, many years ago. And there was a little pushback from some people, but there was more acceptance with other individuals. So I'm just curious if that's been discussed, or if you
I have not heard anything, and really, thank you, Dr. Toney, very wonderful points. But I have not heard anything in the discussions at national meetings about using alternative tetracycline, for instead of doxy. I think people are really comfortable with doxycycline, and since this is driven a lot by STD providers, sexual health clinics, they're all very comfortable using that drug. So I don't know if that's playing into it, but I have not seen anything underway or on upcoming trials using something like minocycline.
Yeah, I certainly can appreciate that. Like I said, several years ago, there was definite pushback from a couple of people who we haven't really used that to treat STDs, although it's FDA approved to treat sexually transmitted infections from a long time ago. So realistically, we did use it in some individuals where they just couldn't afford the doxycycline. I mean, 10 days of doxy, the week before all this went was like $5, and then they wanted, 7 days and it was $200. So, I wonder, what kind of we're looking towards the future and looking at some of this stuff. But I think it's, like I said, 2 out of 3 is not bad, and it gets us some places. And if the outer-membrane vesicle of Bexsero trials for gonorrhea prevention pan out, I think that's another tool perhaps that we can use. But again, thanks very much. I appreciate your time.
Mm-hmm.
All right, Lynette Menezes from International Medicine. Go ahead, Lynette.
And from infectious disease. Thank you, Dr. Sherbuk. That was an amazing talk. Of course, my question I have a couple of questions. One is to do with global. Do you know of global studies that are being planned? And with the whole use of doxy as well as prophylaxis for malaria, I was just curious to know.
That's a very interesting point. I can think of upcoming trials or ongoing trials in Europe and Australia, but I don't know what's the next step for, like, the DPEP trial was based in Kenya. I don't know what's the next step. Their data has just been started being presented at even conferences and isn't even published yet. But I think that's a really excellent point. I didn't talk about, other uses of long-term doxycycline, like malaria prophylaxis, as you mentioned, or for acne. But that could certainly, we know the rates of tetracycline resistance vary globally, and I think that's going to be something to sort out.
Thank you. And then one kind of in terms of policy, I think you kind of answered it. I was curious, given the state of things in Florida. Every day it's like a new day with new challenges. So I was trying to figure out how this was going to fit in, given the kind of high-risk populations that this would be offered to, and whether it was something that was going to be replicated across the health departments in the state?
The state is not always transparent, but from what we've heard, the state is working on a protocol for DoxyPEP internally. In addition to, our local county is figuring out one for ourselves in the meantime while we wait for more official guidance. So far, people have been receptive to that. Most people working in the health department want to care for patients, and everyone recognizes this is an area of high need. So far, so good.
Thank you so much, Jackie.
All right, and we have Dr. Anthony Canella next to joined about the same time you did, Dr. Sherbuk. So you guys are the same inaugural class at USF for ID. Anthony, go ahead.
So Jackie, just to give you some props here to the junior faculty, this is how you present really tough, novel data. Okay, you put forth a pretty good pros and cons for how to present a very interesting and combustible topic in ID right now. And so regardless of what it is for the junior faculty, this is how you do it, okay? That's one. On my points about this whole topic is this. Number one, the M. genitalium issue is a big issue, okay? We know that the only thing we have left that would be oral would probably be levofloxacin, right? Which is not ideal in a lot of patients. So I'm very concerned about that because a lot of people do not look for Mycoplasma genitalium when they're looking for STIs in these people. And it's probably much more of an occult disease, an insidious in presentation than everything else. The staph issue is massive. We know that in populations, especially MSM, and this data has been back from like the early 90s, okay, when I was in high school. We know that the MSM population, that Staph aureus is transmitted a lot more than you would think, and we start to see these infections and even disseminated infections.
I can hear you, yes.
And so somebody's on a hot mic, I think.
I muted them. We're good.
Thank you. And so I think that with the development of an oral option for Staph aureus, that is a big concern, especially with this being used in a ubiquitous form. The last thing, and is if we're going to implement this, there are a lot of other issues to not just the microbiome and everything else. For HIV PrEP, it is with besides the hepatitis B being the bystander, it's really targeting HIV. Okay, this is targeting multiple pathogens. Okay, and again, it opens up Pandora's box. And so, because of all the other issues taking Doxy, where if you're going to take it while you're with your you're eating your bowl of Captain Crunch with berries in the morning, that's not optimal. You're not going to absorb the drug. And so, and there's issues with albumin binding and other things from a PK/PD perspective. So I think this sounds pretty cool, and I think it would be a good thing. I've read the papers just like Jackie has presented, but I have some concerns on those three topics, because if people are just going to take it, not as directed by the physician, and let's face it, if people are taking antibiotics that they have in their medicine cabinet that are not being prescribed for what they're taking it for, then it raises the hairs in the back of my neck for that. So as long as we don't have resistance developed for what I've kind of mentioned, and they're taking it correctly, then and it's done properly, then it should be okay. But we're dealing with human behavior here, people. So hopefully CDC and WHO come out with some good guidelines for this. But good job,
Yeah.
Jackie.
Thank you so much, Dr. Canella, for those points. And you actually hit on a bunch of slides that I took out for the sake of time. Some of them showing things like just the prevalence of tetracycline use in the world, both the millions of doxycycline prescriptions per year in the US, and then also the amount given to livestock. So how does the amount used for this trial sort of factor in? Obviously, you're focusing on a population that, for the STI prevalence at least, is clearly the one to focus in on, and that will be exposed to STIs. But I thought that was interesting. And then the other thing is those parallels with HIV PrEP implementation and what's similar and what's different is really, and some of those are people feel like the world of medicine was slow to get people on PrEP, which turned out to be such an effective tool. And so are people reacting by trying to be really on top of DoxyPEP, maybe before we have all the data we need. So thank you.
All right, am we missing anybody else? Jen, any other? Oh, Sharu, excellent. So the mentor herself,
I
go
was
ahead.
gonna clap. I just used the wrong emo. I'm using the right one now. Sorry.
Okay, anyway, any questions, Sharu?
I have no question. Fantastic presentation. Always.
Excellent, excellent. Excellent. The proud mentor. And yes, she texted me to stop saying 20 years. Jen, any others?
No, we're good in chat.
We're good. And right at 1 o'clock. So 2 straight weeks, we finish at 1 o'clock. That was one of our pledges, our new resolutions for this year. And our 2 presenters have been outstanding. They make it easy for us to finish on time. Great job, Jackie, again. And thank you all for joining us. We'll be back here next week, same time, same channel. So take care.
Thank you.